So now I am audible, sir.
Yeah.
A 19-year-old female, P. Sarala, studying inter, residing at Kolattur, came to the department with chief complaints of post-burn scarring at face, anterior lateral surface of neck, right hand, upper chest since 18 months. Grossly restricted neck movement and inability to look upward. Mouth opening is limited but not restricted. History of present illness. Patient was apparently all right prior to the self-immolation at her home, following which she developed burns involving face, neck, right hand, and upper chest, which accounts 30% of total body surface area. Initially, he was managed at HDU for 5 days and later in burn unit and finally discharged after 1 month of treatment. There is history of repeated dressings, applications of topical antibiotics, systemic medications, and these repeated dressings are done under GA, which are uneventful. Gradually, she developed scar tissue over the face, neck, right upper limb, and upper part of the chest with restricted neck movement and limited mouth opening and unable to look upward. There is no history of stridor, shoot in the sputum, respiratory distress at the time of sustaining burn injury. There is no history of voice change, dysphagia, or there is no history of any airway intervention done at the time of sustaining burn injury. Coming to the history of past history, there is no history of asthma, epilepsy, or any psychiatric illness. Personal history, he takes mixed diet, appetite normal, normal bowel and bladder habit. Family history, nil significant. Treatment history, he has taken no other relevant medical surgical history before the episode. Coming to the general physical examination, the patient is conscious, coherent, oriented to time, place, person, and cooperative, thin build and averagely nourished. Weight is 50 kg, height is 160 centimeter, BMI 19. There is no signs of pallor, icterus, cyanosis, clubbing, no generalized lymphadenopathy, or no history of bilateral pitting pedal edema. Coming to the vital signs, pulse is 94 per minute, regular, normal volume, normal character, all peripheral pulses are felt, condition of the vessel wall is normal, no radiofemoral, no radiofemoral delay. BP measured in left upper arm in sitting position is 104 by 70. Respiratory rate is 16 per minute, breath holding time is 27 seconds. SpO2 is 97 on room A and the patient is afebrile. Coming to the airway examination, mouth opening is 2 fingers or 3 centimeters, modified Mallampati grade 4, thyromental distance could not be measured, upper lip bite test grade 3, unable to protrude the mandible, and on examining TM joint, temporomandibular joint, can't insinuate one finger in front of tragus. Coming to the neck movement, extension of neck is restricted and the lateral rotation are also restricted and there is fixed flexion with around 50%. Both the nostrils appears to be normal and patent. Coming to the local examination, inspection, burn scar present over the face, front of neck, extending laterally up to sternocleidomastoid, involving upper chest above the nipple line. Left side of clavicle is normal, visible, and right side, 2/3 of the clavicle is covered with scar tissue. Scar tissue extending over right upper limb up to the elbow. There are two strong visible bands of scar tissue starting from mentum to the upper part of the chest. Thyroid cartilage is not visible and there is no active ulcers, sinuses, or fistulas. Coming to the palpation, scars are non-tender, appears to be an inspection appears to be mature and they are raised above the skin surface. Coming to systemic examination, respiratory system, inspection, shape of the chest appears to be normal, chest wall examination, chest wall movement appears to be equal on both the sides and there is no intercostal retraction, regular rhythm, rhythm is regular and rate is 18 per minute. Palpation, inspiratory findings are confirmed and vocal fremitus is normal on both the sides. Percussion auscultations are normal and other systems, CVS, CNS, all systems are normal. Coming to the summary A 19-year-old female patient with post-burn contracture for face, neck, upper chest of 18 months duration with fixed flexion, unable to look upwards, scheduled for elective contracture release and with skin grafting under general anesthesia. Coming to the investigations, hemoglobin, routine investigations include hemoglobin, total leukocyte count, PT, INR, APTT, blood urea, serum creatinine, so serum electrolytes, sodium, potassium, and chloride, blood grouping, chest X-ray, X-ray chest, neck, AP and lateral, and ECG. The anesthetic concerns are first and foremost is the patient we are dealing with difficulty airway. There could be a problem with bleeding, so require preoperatively arrange adequate amount of blood, and the patient may prone for hypothermia and postoperative pain management. Okay, thank you.
Okay. Is this patient married?
Unmarried.
Married. Did you mention that?
Okay.
Because this history given question here is she attempted suicide, self-immolation, isn't it?
Yes, sir.
And you say she had no psychiatric problems, isn't it?
Okay.
So if such
Yes, sir.
case scenario is given, it's a very important factor that you find out why she attempted suicide or self-immolation. Because a normal-minded person will not try to kill themselves. So it may be a marital disharmony or a parental disharmony if she is not married, and we should know because the mental status or psychiatric status of that patient is very important in treating such patients. Once they have attempted suicide, they may not be interested in undergoing further treatment and they may not cooperate adequately. But after some time, they may realize their mistake, and then you have to do a lot of counseling and then refer them to a psychiatrist to get back to their normal senses, and then only the treatment will be successful. So you have to see whether it is an accidental burn or a suicidal burn. That is a very important part of the treatment itself. Okay. Right. Anyway, now this sort of questions, cases are kept in the exam, as Madam said, mainly for it is a case of clear-cut case of anticipated difficult airway, isn't it? So now you said you wanted some investigation. We have done some investigations also. You have mentioned.
Yes.
What are the X-ray investigations you have done in this patient?
Yes, sir. X-ray neck, sir. AP lateral to look
What
for.
What do you want to see in that X-ray neck?
Sir, maxillo-pharyngeal angle, sir.
Very good.
Usually it is more than 100 degrees.
Normal maxillo-pharyngeal angle?
It will be more than 100 degrees, sir.
More than 100 degrees.
100 degrees. If it is less than 100, depending on the grading of maxillo-pharyngeal angle, you can grade 100 to 90, 80.
Okay. So the difficulty or the degree of fixed flexion deformity can be easily assessed by measuring this maxillo-pharyngeal angle. Okay. How is it measured? How do you suppose you are given a lateral view in a head and neck? How will you measure the maxillo-pharyngeal angle in the exam if they give you a X-ray like that?
Neck X-ray, sir. Usually electronically we can get the angle, but we can.
Supposing they give you a plain X-ray of the head and neck and try to ask you to measure the angle, how will you do that?
Yes, sir. One scale we can keep over
the radiologist. But if that is not available, how do you draw the lines? That is the main.
Yes, sir. One scale you can keep above the maxilla, sir. And the second scale comes
around. First line should be parallel to the hard palate, not as maxilla. It should be parallel to the hard palate, and the pharyngeal line should be parallel to the body of the first and second vertebra. Okay? The straight line drawn abutting the body of the first and second cervical vertebra will give you what is called the pharyngeal line, and the line drawn parallel to the hard palate, or more specifically passing through the anterior and posterior spines of the nasal bone. That will be the nasal line. So or maxillary line. So when the angle at which these two cross each other is the maxillopharyngeal angle. In a person who is able to extend the neck, it will be more than 100 degrees, 100, 110. Whereas when it gets flexed, it becomes an acute angle. Less than 90, it will become 80, 70 like that. And that person cannot extend the neck at all. So the normal position we need for a laryngoscopic intubation, we need an extension, isn't it?
Yes.
Flexion of the cervical spine and extension at the atlant-occipital joint. That is what we require. So that will not be possible if you have a fixed flexion deformity, and that is the main reason why these cases throw a challenge for securing the airway. Now the common question, as Madam said, the examiners want to know is how are you going to manage this case for this proposed surgery? What are the options available for you? What is the gold standard treatment?
Anesthetic plan includes awake fiber optic intubation.
Very good. Okay. So
first plan A is awake fiber optic intubation. If you are trained and your equipment is available, if the patient is uncooperative or mild less cooperative, with sedation we can do awake fiber optic intubation.
Okay.
If the technique is not sure and not available, we can go with the help of the surgeon by releasing the contracture under local and ketamine sedation 0.5 mg per kg. We can release the contracture and we can do video laryngoscopy or supraglottic airway depending upon the initial assessment of the airways. What is the mouth opening? Or the last option, we can go with tumescent anesthesia, sir, under local anesthesia. But yes, sir, these are the various plans.
Very good. Okay. So these are the three options. Previously, they used to say that you can try awake blind nasal intubation also, but some examiners don't agree with that because the anatomy is distorted and the neck is in acute flexion. But in my experience, we have succeeded in a lot of cases by blind awake intubation itself without fiber optics. But the modern day examiners don't agree with that. So these three options what you have given are the correct answers for this short case scenario. Awake fiber optic intubation under topical anesthesia. That terminology should also be included in the answer. You can't do an awake fiber optic intubation in an unanesthetized or untopicalized airway. So the next question that may come to you in this sort of scenario is, how will you anesthetize the upper airway and lower airway for doing an awake fiber optic intubation? What are the common nerves that have to be blocked, and what are the sensory supply to all these areas? How do you block them, and how do you do an awake fiber optic intubation?
First is nares, sir, anterior ethmoidal nerve and sphenopalatine. It can be blocked by administration of nebulization with 4% xylocaine with adrenaline, or by placement of soaked saline soaked gas pieces with xylocaine and adrenaline and kept intranasally application, so that we can block the nares. So coming to the oral cavity, glossopharyngeal nerve can be blocked. It can be blocked by administration of the nebulization or 10% xylocaine spray. If there is an efficient mouth opening, then we can give 10% xylocaine spray to anesthetize the oropharynx, base of the tongue, blocking the glossopharyngeal. So next technique is spray as you go, Sago technique. Whenever you pass the awake nasal fiber optic infusion, we can spray the xylocaine spray as you go to the awake fiber optic during awake fiber optic, or we can use atomized nebulizer technique, can also be used to anesthetize the air.
Okay. Now, as you say, when the patient is non-cooperative, in spite of your nebulization or application of local anesthetic, still the patient is, because he already had a psychological problem by self-immolation, so since he is uncooperative. What will you do?
Sir, we can sedate the patient, graded dose of propofol.
Sedate with what exactly, and what are the
Dec-
advantages and disadvantages of sedating a patient with a fixed flexion contraction?
Sir, we should give first initially pre-medicate with the glycopyrrolate 0.2 mg. So we can use the dexmedetomidine infusion, the patient, graded infusion. But before starting any infusion, make sure that ventilation is proper. You can ventilate the patient properly. There is no doubt in ventilating the patient, and make sure that all gadgets are available, and the senior anesthetist should be informed, and we should take the help of a senior anesthetist before starting the case. So if the patient is uncooperative, graded doses of propofol with ketamine with midazolam can be given. Make sure the airway is not compromised.
Make sure mask holding and ventilation is possible at all times. That is the
At all times. Yes.
You have to make sure that you can hold a mask and ventilate the patient all time by to maintain the oxygenation of the patient, which is a very important part in the management of uncooperative patients. Or similarly, children, pediatric patients also, you can't expect them to cooperate. So in that case also, preserving the spontaneous ventilation and confirming the ability to mask ventilate and oxygenate the patient are the two most important criteria for giving sedation or mild induction that makes the patient cooperate for an intubation. So it will not be awake, it will be a sedation or a inhalation anesthetic technique for inducing anesthesia, but never use a muscle relaxer. That point has to be insisted in your examination answer. I will never use a muscle relaxant and leave the airway and land up in a situation of can't intubate, can't ventilate scenario. That answer it will be, that examiners will be very much satisfied. Now, suddenly some examiners may jump to ask about fiber optic scope that you are using. What is the physics involved in the usage of fiber optic scope? I have seen some examiners just out of boredom of asking the same questions to all the candidates, suddenly ask about the instrument. So what is the physics involved in the working principle of a fiber optic scope?
Prism illumination.
Hmm?
Prism.
Prism. This is how suddenly you'll getting caught in the examination. If you say one answer, two words you have to say. Total internal reflection. Okay? It works on the principle of what is called total internal reflection, which is done by number of cables, which are just as what is the size of a fiber optic cable that is it a single cable or multiple cables? The cables are as thin as your hair. Okay, so many number of cables are bound together, and each cable has got four parts: a core, a cladding, a buffer, and a jacket. These are all the four layers of each cable, and they have a light source which is kept separately, and this light will pass through these cables at an angle which is called an angle of incidence. Then it gets reflected, and that reflected light again gets reflected by another cable and then goes on like a wave. So the source what is given is augmented several times and rapidly passed on to the tip. So what is the advantage? Why we are using this sort of cable for visualizing the airway? Have you ever seen the light box that is separately kept during this fiber optics usage? Have you ever touched that box? Will it be very hot or cool?
Use ambush.
Are you there? Jay Bharati, you there? All of you would have seen a fiber optic scope being used, isn't it? In
Yes,
your
sir.
training so far. Have you seen that box light source where you insert that metal part of the cable into that for transmission of light? So we call it as cold light source because the light is far away. The source of the light is far away and it gets transmitted to the tip of the fiber optic scope. So it is not going to be hot at all because we are going to use it very close to delicate structures like the respiratory mucous membrane. We don't want any burns. So it is called the cold light source. By the time the light reaches the tip, it loses all the heat energy and only the light energy goes there. Okay? And what is the most important practical tip you have to follow when using a fiber optic bronchoscope or a laryngoscope for intubation?
Blood or mucus don't not very
Hmm?
clear. Vision should be clear, sir. No blood or
Things should be clear, but what about handling that fiber optic cable? What you should
uh,
not do?
Not
should
bending.
not
Should
bend
not be
bend
bent at all. It should
bend
be
bend.
straight.
Cables
Bend.
should
Okay?
be gone.
So you must always hold it at
Straight.
straight like that without bending that and try to visualize through the eyepiece and try to. Or nowadays we have the monitors which are attached to the scope, so you don't have to look into the eyepiece. You can see the monitor and try to intubate. Okay. Suddenly this question may be asked. I have seen an examiner asking this question: how you clean the fiber of scope? How do you preserve that? All of you would have seen the scopes are all always hung from a large case, isn't it? Or kept with a large circle, not acutely bent inside the box. Hmm? And how do you clean them in between use? How is the urologist clean their instrument, endoscopes?
Direct solution will be
Cydex solution. The same thing you can use, but you have to rinse it with saline after. After dipping it in Cydex for at least 20 minutes, you can remove them and rinse it nicely with saline to remove all the Cydex chemical and then only use it. Okay. So
okay,
please
sir.
remember all these points. Suddenly, if the examiners ask you in practical exam, you have to remember all these points and tell them. Okay, right. So the common questions you have to know about the nerve supply, sensory nerve supply to the upper airway, methods of blocking it, and then usage of vasoconstrictors or the mucosal sphincters like Macevian or Otrivin before application of attempting fiber optic intubation is also very, very important. Okay, so that you can avoid bleeding. And in this situation, sometimes you may be asked about Moffat solution, which is a very obsolete procedure which was done long back by most ENT surgeons. And if you answer very well like this, just to give you extra marks, they may ask you about Moffat solution. And I think I have shown that in one of the ASCII descriptions also. What is Moffat solution and who used it or who introduced it? Any idea?
It's NS, a combination
Huh?
of NS is xylocaine and sodium
Not,
bicarbonate.
no, it is not xylocaine. It's before the xylocaine era. Pratik
Cocaine,
Shukla,
sir. Cocaine, sir.
is there?
Cocaine.
Cocaine,
Cocaine
sir.
soda
Cocaine,
bicarb.
yes. It's 10% cocaine with adrenaline and bicarbonate
Soda bicarb.
used as a nasal for 2 ml, 1 ml, and 1 ml. So 4 ml total. As this diluted to 10 ml with this water or saline and then used as a surface anesthetic. It's a gas piece soaked in that. You just apply it over the nasal mucosa inside. You pack it for leave it for some time. So it was introduced by one Dr. Muffet, who was a retired army surgeon, ENT surgeon, who used it for his nasal reconstructions, nasal repair, septoplasties, and all those things. So he was the one who introduced it. He claimed that absolutely no bleeding because of the adrenaline. Cocaine also has a vasoconstrictor effect. It helped in shrinking the mucous membrane, so passage became free, and bicarbonate reduced the irritation produced by these drugs, acidic drugs. So that is the composition, right? So with all this,
Supraglottic, sir. So supraglottic airway devices. Supraglottic airways.
yeah, supraglottic airway device is
Intubating airway and
Right.
intubating airway.
if you are able to introduce that with an adequate mouth opening, then that is another choice where you can introduce it even at topical anesthesia when the patient is awake and see whether the bag movement and bag fillings are adequate. Because in a fixed flexion deformity, sometimes the placement or seating of the LMA may be not very good. It may try to come out because the normal extension that you require may not be adequately there. But they have done with iGel more than the conventional LMA designed by our
Brain.
brain. iGel seems to be a better choice for the maintenance of the airway. And as she said, you can use
Intubating LMA also.
intubating
Intubating
LMA
LMA is used.
also going to be, but all that is little more cumbersome in these cases. It's not a straightforward use, it cannot be done. And,
So also somewhere I read about the use of nebulization, and they say when for upper airway, anesthetizing the upper airway, nebulization is not extremely very good because it's more for the lower airway. I mean, like I really don't know because that's a study. I read that, and then it says nebulization is more for the lower airway, and that's why it's more useful for asthmatics and all that. And for anesthetizing upper airway, nebulization is not the method of using it.
but many these webinar classes, I find most examiners accept the answer that you can nebulize using
So, yes, sir. Yes, sir.
xylactate. So the main aim is now to pass the exam. So
Yes, sir.
exam you can say that as an answer, right? So when you want to, when such facilities are, I mean, such restrictions are there in mouth opening as well as the neck extension, and you have to do it a quick release in consultation with the surgeon, you have to have a good rapport with the surgeon and talk with him, and then make sure that he is quite good enough and fast enough to release the contracture under the effect of ketamine. And even when you give ketamine in small doses, make sure that you are able to manage the airway with mask ventilation or preserving the spontaneous ventilation. Because we had almost total arrest in one case after giving just 25 milligrams of ketamine for an adult for a release like that. And we had such a difficulty to relate the patient because the patient suddenly, even with 25 milligram, became totally apneic. And such complications can occur, so you have to be very, very watchful when you use propofol or pepentone or ketamine, and that is a very important thing that you have to keep in mind. And, so sometimes they may ask you about the type of scars. If somebody like me who has worked in plastic for a long time and I have an association with plastic surgeons, they will ask you about what are all the types of scarring that happens in the front of the neck. How do you describe the stars, whether it is a linear scar or a broad band scar? Okay? And then the grading.
immature or mature scar.
So how do you differentiate between mature and immature scars?
Sir, vascularity, sir. In immature, vascularity will be present, sir. In mature, there won't be much of vascularity.
Yeah. So during the healing period, a lot of new vessels form. So the scar will be quite pinkish and it will blanch when you press it. Whereas once it has become mature, there is keratinization and the color itself changes into almost dark brown or blackish, and all the blood vessels disappear. So, which is the ideal time to operate during immature scarring
Mature,
or mature scarring?
mature scar, sir. Mature
You
scar.
have to
Bleeding
wait.
will.
You have to wait for the scar to become fully mature so that you don't have unnecessary bleeding. And lastly, coming to the tumescent local anesthesia. What is the composition of tumescent local anesthesia? Who introduced this? Is it for this burns contracture purpose? Was it used, or who introduced it and for what purpose?
Sir, it introduced by Jeffrey Klein, sir, in dermatology. He
Dermatology.
introduced the technique.
Yeah.
He introduced the technique. Idea original preparation is normal saline 1 liter, 1% xylocaine 50 ml, epinephrine 1 ml, 1000
Yeah.
soda bicarb 12.5.
Hmm.
That is the original solution used, and
Hmm.
later on it's modified by Hunstead using RL 1 liter.
Very
Because
good.
it causes
Hmm.
less pain, less pain.
Okay.
We can use
Hmm.
nowadays, but we should be careful for last and pulmonary fluid over.
Cool, bro.
We should
So,
be
what are
careful.
the intraoperative cardiac problem that you can get with tumescent local anesthesia?
Sinus arrhythmia can occur with adrenal insufficiency.
Mostly
Sometimes
bradycardia. Sinus
bradycardia will
bradycardia is the most common complication.
lignocaine.
And sometimes you may get hypertension also if you are not very careful about the uh, making of the. Sometimes by mistake people add 2 or 3 ampoules of adrenaline without knowing the proper composition. Especially if you tell the theater boy or theater sister to mix the missing solution. Mistakes have happened where they have added 2 or 3 ampoules of adrenaline without knowing if you inject, you will end up with systemic toxicity, which will result in severe tachycardia and hypertension. Okay? And how do you know that your tumescent effect has taken up nicely? You are injected.
I mean, there will be vasoconstriction, so there won't be bleeding. No
If
bleeding will be there.
wherever you are able to see some small blood vessels in the superficial area, they will all become blanched in the whole that area. You have to carefully observe the color of the scar. The scar which is pinkish before you start the injection will become pale because of the vasoconstriction. That is the ideal time to allow the surgeon to start the surgery. So that is a very good indicator because we have done more than the cases where using only ketamine, I mean only tumescent, we have excised very severe contractures also and succeeded in avoiding doing GA. So the problem of fiber optic or awake intubation are all avoided by doing it with total tumescent triple anesthesia itself because its abnormal is such a. So what are the advantages claimed for tumescent local? Apart from
Tumescent,
that, it is easy, technically very easy. Any other advantage?
bleeding will be less, sir.
Very good.
A graft, whatever will
Uptake
keep, it
is
will be
also very good.
very good.
And you can assess the degree of release. If the patient is conscious, you can ask them to look up and see whether there is any bands which are still holding. Okay? So, and the release can be complete. And you can get a very satisfactory release. And the xylocaine that you use is supposed to uh, act as an antiseptic. So the chance of infection, antibacterial rather. So the infection and the rejection of graft is also very much reduced by local anesthesia. And so these are the points that we have to remember with regard to the neck contracture. But sometimes, as Madam said, sometimes they may ask you about the acute burn stage instead of asking for the management of this contracture. If they ask you about acute burns, uh, How do you fluid resist it? This is the major burn or a minor burn? This patient, when they have suffered this and come to the hospital 1 month ago or 6 months ago, whatever period they were admitted.
It's a
Is it
major
a
burn.
major burn or a minor burn?
Major burn. Major burn.
Major burn. So what are all the conditions which will be classified as major burn?
Sir, major burn is full thickness burn, more than 30% classified as major burn. Or
Should it be
if
always
it is
full thickness or it depends on
partial
the extent?
extent also, sir, head and neck and chest.
Area
Right
involved also
area.
is the first thing is area involved or the extent of burn. Then comes the depth of the burn. Okay? The first criteria is always area or the extent of the burn. So percentage classification. So what are all the formula that are used or the guidelines which are used for assessing the extent of the burn, not the depth?
Rule of 9, sir.
Rule of 9 for adults.
Yes, sir.
Can it be used for children also?
Lund and Broader chart.
London Broader, very good. So there are two things. One for pediatric, London Broader. For adults, you use Wallace 9. Any other recent method introduced by an army chap? We have seen a lot of burns in the army, soldiers in chemical warfare and radiation warfare. Any app which is used or included to the cell phone, modern iPhones, can they be used? Nowadays, the fashion is to use your iPhones for giving anesthesia. Artificial intelligence, everything is coming on in a big way, isn't it? Do you know any app which is used using your iPhone? It's an app called Merce, M-E-R-S-A,
Merce.
Merce app, which is also used. You have to just, there will be a diagram of a person. So looking at the patient, you have to just scratch all the areas where you find the burns are. For example, in this case, you have burns in the right cheek, neck, part of the chest, upper limb. When you just shade all these areas with your finger, immediately it will give the percentage of burn, that is extent, as well as the fluid that you have to be given to the patient. Okay, all these things will come a platter for you easy. You don't have to remember any formula like Parkland or Brooke formula. So fluid resuscitation is the next question. So extent of the burn calculation is one question. Fluid resuscitation is the another question. What are the formulas that are used?
Parkland formula, sir. Its formula is 4 ml into body weight into percentage of total body surface area burned. Fluid given for 24 hours is half of the calculated fluid should be given within 8 hours, sir. That is ringer bracket, and the remaining within 16 hours. Then we can do other formula is Brooks formula. It is 2 ml into body weight into body surface area and area burnt, and the duration RL is given, and the same half should be given within 8 hours, remaining 16 hours. Next is Evans formula. In this formula, normal saline is used at the rate of 1 ml per kg per percentage of body surface area for the first hour. For second 24 hours, we give half of the first 24 hours requirement, that is D5W.
What fluid do you use?
Sir, Park and Ringer's lactate.
Is there any new fluid that is being introduced which is tried instead of finger lactate?
Isolate the plasma.
Plasma lactate, yes, very good. So why people were using only finger lactate instead of normal saline or dextrosaline? What is the common reason? We have been using finger lactate for ages for burns. What is the reason? No. Am I audible?
Yes, sir.
Yes, sir, you're audible, sir.
Yes, sir.
You're quite-
No answers. Okay.
Ringer lactate is a balanced salt solute and we require
Yeah.
multiple electrolytes also to be restored along with the volume, sir.
The earlier concept was it is almost isoosmotic, and then it has a lactate which is getting converted to bicarbonate to prevent the acidosis that can set in. But nowadays, after so many years of use, now after the advent of plasma light, ringer lactate is now going in the back seat. Why? What is the advantage of using plasma light over ringer lactate for burns resuscitation or any critically ill patient resuscitation?
Citrate is
Plasmol
there
is equal
instead
to
of
plasma, sir.
Yeah,
Plasmol
electrolyte
serum
composition is almost equal to
plasma.
normal electrolyte composition in the blood. Whereas the fluoride is very high, and the amount of lactate is very low because excess lactate can produce lactic acidosis. So even smaller quantities until the liver can manage, it will be converted to bicarb. But if you give too much of ringer lactate, lactic acidosis will set in. So the advantage of plasma light is lesser lactate content is there. And another major advantage is it doesn't have any calcium like what you have in ringer lactate. So if you want to give blood also, you can give it immediately after giving plasma light. It will not allow the blood to clot. Whereas when you use ringer lactate, you have to always flush the line with a normal saline and then only use blood whenever you are going to use blood substitution. So these are the newer things that you have to remember with regard to fluid resuscitation. So these are all the points that you have to remember. I think we have shown all the earlier PPTs for both these things. Do we have time to just go through those PPTs again slowly? I mean, as a past revision. Would you like to see that?
Yes, sir.
Yes, sir.